Welcome to the deep dive. Today, we're going to be diving into a topic that I think every GP encounters, quite regularly, and that is benign breast diseases. And I think it's something that can sometimes cause a lot of anxiety for our patients,
They really can.
and sometimes it can be challenging for us as clinicians. Just given the variety of different conditions that fall into this umbrella.
Hmm.
And did you know that at least half of all women will experience a non-cancerous breast lump at some point in their lives?
It's a really staggering statistic.
It is, yeah. It's really quite a lot. So we're going to unpack all of that today, and we have a fantastic expert here to guide us through the latest guidelines and best practices for managing these conditions.
Yeah, and it's a great topic to dive into because, even though these conditions are very common, they can be surprisingly complex. As you said, benign breast disease, it isn't just one thing, it's a whole spectrum of disorders, some much more common than others. And the real challenge, I think, for GPs is that many of these benign conditions can actually mimic breast cancer,
Right.
both in how they feel and how they look on imaging.
Yeah.
So, today we want to go beyond just sort of listing out the different types of benign breast diseases, and we'll really unpack how these conditions are classified, what the research tells us about their management, and most importantly, how you can use this knowledge to confidently diagnose and treat your patients in your practice.
Yeah, I think that's so important. When I think about benign breast disease, I think my mind immediately goes to those simple breast cysts, fluid-filled sacs, and it's so common that women experience these. Um, and they can be painful, but generally, we reassure patients that they're not linked to cancer. So are those cysts, are those sort of part of a larger category?
Yeah, absolutely. So those simple cysts, they fall under that umbrella of non-proliferative lesions,
Right.
which are the most common types of benign breast changes. And the really reassuring thing is that most non-proliferative lesions don't increase a woman's risk of developing breast cancer.
Okay, that's good.
So the focus there is really on just reassuring the patient and managing any discomfort that they might be experiencing.
Okay, that's really good to know. So you mentioned non-proliferative lesions. Are there any other kinds of, I guess, non-proliferative lesions that, we might see in our practice?
Yeah, so you might come across things like galactocele, which are milk-filled cysts that typically occur during breastfeeding or shortly after.
Hmm.
And then there's a condition called papillary apocrine change, which involves a proliferation of cells in the breast ducts. But again, these are both generally considered benign.
Okay, so I've got the non-proliferative lesions, and now I know there's another category called proliferative lesions where things
Okay.
get, you know, I think a little bit more complicated because there's more cell growth involved, and so that naturally raises some concern, right?
Exactly. Proliferative lesions is where things get a little more nuanced. So we divide them into two categories, and it's all based on whether or not something called atypia is present.
Okay.
Atypia basically means that the cells, they look abnormal under a microscope.
Okay.
They're sort of showing some precancerous changes, which increases the risk of developing breast cancer later on.
Got it. So let's talk about proliferative lesions without atypia first.
No.
What's the overall risk level there? And maybe we can talk about some examples of these conditions.
Sure. So the good news is that the risk associated with proliferative lesions without atypia is still relatively low. It's about 1.5 to 2 times that of the general population.
Okay.
And there are a few key players in this category that I'm sure you encounter pretty frequently in your practice.
Yeah.
Some are very easy to manage, like usual ductal hyperplasia, for instance,
Okay.
which requires no treatment at all, and it's just really about reassuring your patients. It's just an increase in the number of cells lining the milk ducts, but there's no atypia, so it's not a huge concern.
That makes sense. So we've got those sort of reassurance cases on one end of the spectrum, but then there are also conditions, I imagine, that require a bit more attention.
That's right. So on the other end of the spectrum within this category, you have things like intraductal papillomas,
Okay.
and these are growths within the milk ducts, and they can actually sometimes cause nipple discharge, which can be a really worrisome symptom for patients, especially if it's bloody.
I can see that being a really big cause of anxiety for a lot of patients.
Absolutely. So how do we manage those intraductal papillomas?
So the management, again, hinges on whether or not there's atypia present.
Okay.
If we do see atypical cells, surgical excision is typically recommended.
Okay.
But for smaller papillomas, without atypia, especially those that are discovered incidentally, close imaging follow-up might be a reasonable option.
Yeah.
But of course, this is an area where clinical judgment and shared decision-making with your patient are really important.
Yeah, that makes sense. So those are intraductal papillomas. What other, I guess, non-proliferative lesions without atypia should we be on the lookout for?
So there are fibroadenomas, which are actually the most common benign tumors in the breast.
Okay.
They're thought to be hormone-related, and they're much more common in younger women. And the great thing here is that imaging can be really helpful in diagnosing fibroadenomas. It can actually help you avoid unnecessary biopsies, which is always a good thing.
Absolutely. I'm sure many of our listeners have diagnosed countless fibroadenomas in their practice.
Oh, yeah, for sure. So we talked about those. Are there any other conditions that kind of, I guess, maybe mimic cancer a little bit more closely on imaging?
Yeah, two more to kind of keep in mind are radial scars and sclerosing adenosis.
Okay.
So radial scars can look like a starburst on a mammogram, and that can mimic the appearance of cancer.
Uh-huh.
So that's where we need a biopsy to be absolutely sure. And then sclerosing adenosis, this is another one that can sometimes raise suspicion on imaging, and it carries a slightly increased risk of breast cancer compared to the general population.
Okay.
So it's just important to be aware of those and approach them with appropriate caution.
Yeah, so those are kind of the trickier ones, even within that, I guess, generally low-risk category.
Yeah.
But we can't forget about that third category you mentioned earlier, proliferative lesions with atypia.
Right.
Um, I imagine those are the ones that we really worry about, right?
They are. That's the high-risk category. When we see atypia, it means those cells are showing some precancerous changes, and it significantly increases the risk of developing breast cancer later on.
Okay, so what are some examples of those high-risk lesions, and how do we manage them?
So the big ones in this category are atypical ductal hyperplasia, ADH, atypical lobular hyperplasia, ALH, and then lobular carcinoma in situ, LCIS. Because of that higher risk that's associated with these lesions, management can be more intensive.
Okay.
This might involve medications like tamoxifen or raloxifene to try to reduce the risk, or it might involve increased screening to try to detect any early signs of cancer.
Wow, so there's a lot more to benign breast diseases than I initially realized. It's not just about reassuring patients about simple cysts.
Yeah, it really is a whole spectrum.
Yeah, it really is.
And understanding the nuances of these different categories is really key to providing, the best possible care for our patients.
Absolutely. So we've covered those three main categories: non-proliferative lesions, proliferative lesions without atypia, and then proliferative lesions with atypia. Now, I know there are some less common benign conditions that can, I think, maybe throw us off a little bit. Are there any that we should be aware of, especially in general practice?
Yeah, definitely. A few that come to mind are diabetic mastopathy, fat necrosis, and then hamartomas.
Okay.
Let's start with diabetic mastopathy. As the name suggests, it's more common in women with type 1 diabetes.
Okay. And what makes this one tricky for us as GPs?
So what makes diabetic mastopathy challenging is that it can present as these really hard, poorly defined masses, and it can be very difficult to distinguish from cancer clinically and on imaging.
Okay, so biopsy is essential in those cases.
Absolutely.
Okay.
A core needle biopsy is usually needed to confirm the diagnosis, but the good news is that once you have the diagnosis, you don't usually need to do an excision unless the patient is symptomatic.
Okay, that makes sense. What about fat necrosis? What are the key things to know about that one?
So fat necrosis is typically caused by injury to the breast, either from trauma or surgery, and it can lead to the formation of these oil cysts, which are basically collections of liquefied fat.
Got it.
And they can show up on imaging, making it look like a concerning lesion.
So another one that can mimic cancer on imaging.
Right.
What's the approach there?
And again, like with diabetic mastopathy, a biopsy is going to be the most reliable way to get a definitive diagnosis and rule out anything more serious.
All right. And finally, what about hamartomas? What are those?
So hamartomas are really interesting because they're basically a mix of different normal breast tissues all jumbled together.
Okay.
They present as painless lumps, but they can raise suspicion on imaging because they look a little unusual. But the good news is that they're rarely associated with cancer.
So observation might be a reasonable approach in some cases.
Exactly. If a hamartoma is discovered incidentally on a mammogram and it's not causing any symptoms, we can often just monitor it with regular follow-up. But if it is causing symptoms, or if there are any red flags on the imaging, a biopsy is going to be the safest course of action.
This has been incredibly helpful so far. I already feel much more confident about, I think, recognizing and categorizing the various types of benign breast disease.
I'm glad to hear that.
Yeah.
But this is really just the foundation. Now we need to talk about how all this knowledge translates into your clinical practice, how you actually use this information when you're seeing patients.
Sounds good. Yeah, let's dive into that.
Okay, so let's shift gears a little bit and actually talk about how you can apply this knowledge to your practice. So imagine a patient comes in with a breast concern. Where do you even begin?
Well, I think it all starts with the fundamentals, right?
Absolutely.
A thorough history and physical exam are going to be crucial in these cases.
Absolutely. And during the history, you want to pay close attention to the patient's symptoms. So things like any pain or nipple discharge. Ask about the location and the characteristics of any lumps they've noticed. And don't forget about their family history of breast cancer and any personal risk factors they might have.
Right. And then we move on to the physical exam and carefully palpating the breasts, the underarm area, really just trying to assess for any abnormalities.
Exactly. And depending on the patient's age and what you find on the history and exam, imaging might be the next step.
Yeah, and that's where it can get a bit tricky, I think, especially when we're trying to decide, which imaging modality is really the most appropriate for the situation.
Yeah, it can be. So for women over 40, mammography is often our first-line imaging test, especially if they have a palpable lump or anything suspicious on exam. But for younger women with dense breast tissue, ultrasound is often a better choice. It can really help us distinguish between those fluid-filled cysts and solid masses, which can be a really important distinction.
Yeah, that makes sense. I sometimes struggle in my practice with, when is an MRI really necessary?
Yeah.
What are your thoughts on that?
So MRI can be incredibly valuable for evaluating, I think, those complex cases where mammography and ultrasound are inconclusive. It's also a key tool for high-risk patients, such as those with a strong family history of breast cancer or known genetic predispositions.
Okay, that helps clarify things. So we use imaging to really try to get a clearer picture of what's going on, but often a biopsy is the only way to really get a definitive diagnosis.
100%. The biopsy is the gold standard for determining whether a breast lesion is benign or malignant.
And I know there are different types of biopsies available. How do we choose the most appropriate one?
So the choice of biopsy technique really depends on the characteristics of the lesion and also the clinical scenario. So fine needle aspiration is often used for simple cysts, both to diagnose and also to provide relief by draining that fluid. But for solid masses, a core needle biopsy is usually preferred because it gives you a larger tissue sample, which allows for more accurate analysis by the pathologist. And in some cases, a surgical biopsy might be necessary, especially for lesions that are difficult to access with a needle.
Okay, so we've talked about how to reach a diagnosis. Now let's kind of move on to the management side of things. And I imagine the approach varies widely depending on the specific type of benign breast disease that we're dealing with.
You're absolutely right. Management is tailored to the individual patient and their diagnosis. So, for many women with those simple non-proliferative lesions, like we talked about before, reassurance and monitoring are all that's needed.
Yeah, that makes sense. But what about conditions that do require a bit more active treatment?
Yeah. So, for symptomatic cysts, aspiration, as we mentioned, can often provide immediate relief. And if a cyst keeps coming back, we might consider surgical excision. For some of those proliferative lesions with atypia, medications like tamoxifen or raloxifene might be recommended to reduce the risk of breast cancer.
Okay, and I imagine close follow-up is crucial for many of these patients. How often should we be seeing them back, and what type of monitoring is needed?
Yeah, the frequency of follow-up really depends on the specific diagnosis and the individual patient's risk factors. So for lower risk conditions, clinical breast exams and imaging every 1 to 2 years might be sufficient. But for higher risk lesions, more frequent monitoring might be necessary. And of course, we need to educate our patients about self-breast exams and encourage them to report any new or concerning changes right away.
It sounds like communication really plays a huge role in managing these conditions. How can we be, I guess, most effective at really addressing patients' anxieties and concerns?
Yeah, you've hit on a really important point. These conditions, they can be incredibly stressful for patients, even when we reassure them that it's not cancer. And open, honest, and compassionate communication is absolutely key.
So what are some practical tips maybe for communicating effectively in these situations?
Well, first and foremost, we need to really listen to our patients. Acknowledge their fears, validate their concerns, use clear language when you're explaining the diagnosis, make sure it's easy for them to understand, answer their questions thoroughly and patiently. And, we need to be realistic about potential risks without being alarmist.
Yeah, I often find myself struggling to find that balance.
I think that's a common challenge for all of us.
Yeah.
It can be helpful to use visual aids or diagrams to explain things and always encourage patients to ask questions and share any concerns that they have. Remember, it's a two-way conversation. It's not a lecture.
I think those are really helpful tips. Now, earlier, You briefly mentioned shared decision-making.
Right.
Can you elaborate on what that looks like in practice, especially when we're talking about benign breast diseases?
Yeah. So shared decision making is all about empowering patients to actively participate in choosing their treatment plan. So it's about moving away from that traditional model where the doctor just dictates what needs to be done. Instead, we're involving the patient in this collaborative discussion, exploring their values, their preferences, and their goals.
I love that approach, but practically speaking, how do we actually implement shared decision-making in, a busy clinic setting?
It starts with ensuring that the patient feels heard and understood.
Yeah.
Take the time to really listen to their concerns, their anxieties, and then clearly explain the different management options, outlining the potential benefits and risks of each approach. And don't be afraid to acknowledge when there isn't one right answer.
So it's about really presenting the information in a balanced way
Ah,
and allowing the patient to kind of weigh the pros and cons based on their individual circumstances.
exactly. And don't underestimate the power of things like decision aids or pamphlets. Those visual aids can be really helpful in making complex information more digestible for patients and facilitating those conversations.
Yeah, this shared decision-making approach makes so much sense, I think, both ethically and practically. It really feels like a game changer in how we approach patient care, especially for conditions like benign breast disease, where there's often a lot of nuance and no easy answers.
I completely agree. And studies have actually shown that shared decision making can lead to better outcomes, increased patient satisfaction, and even improved adherence to treatment plans.
That's fantastic. This has been an incredibly insightful discussion so far. We've covered a lot of ground from, the classification and diagnosis of benign breast diseases to the importance of effective communication and shared decision-making.
Yeah, it's been a great discussion, but we're not quite done yet.
Okay.
There are a few more crucial points I want to touch on.
Okay, let's hear 'em.
So, we've talked about all these different types of benign breast diseases, how we diagnose them, how we manage them. But what about those tricky cases?
Yeah.
Where things aren't so clear cut, where maybe a benign condition is actually mimicking breast cancer.
Right, right. Those are always the tough ones. And I think, it's something that we have to be very mindful of because we know that a lot of these benign breast conditions can actually look and feel like cancer on exam and even on imaging. So it's really important to maintain that high index of suspicion and be comfortable ordering those biopsies when we need to.
Absolutely.
I think back to, those radial scars that we were discussing earlier. They can look so worrisome on a mammogram.
Oh, yeah.
It really raises our concern for malignancy.
For sure. And I think it really highlights why understanding those specific characteristics of both benign and malignant lesions is so crucial.
Right.
For instance, benign lumps, they tend to be smooth, they're mobile, and they're well defined,
Yeah.
whereas malignant lumps are more likely to be hard, fixed, and kind of irregular in shape. But,
But there are exceptions.
there are always
Right.
exceptions.
Right.
That's why we can never rely solely on those characteristics. We have to take into account the patient's age, their risk factors, what their symptoms are, the imaging findings. It's all about putting the pieces of the puzzle together to come up with the most accurate assessment.
So let's say we've done our due diligence, we've ordered the imaging, the biopsies, and thankfully it's confirmed to be benign. What
Right?
happens next?
Well, that really depends, again, on the specific condition, the patient's symptoms. For some women, simple reassurance and monitoring are going to be all they need. But for others, we might need to think about treatments to alleviate symptoms or reduce their future risk of breast cancer.
Okay, so can you maybe walk us through some specific treatment approaches for the different types of benign breast lesions? Let's start with those common breast cysts.
Sure. So for symptomatic cysts, aspiration can often provide immediate relief. And if that cyst keeps coming back, we might think about surgical excision. But for simple cysts that aren't causing any bother, just observation is totally reasonable.
Okay, that makes sense. What about fibroadenomas? I feel
Yeah.
like I see those so often, especially in younger women.
Yeah, absolutely. So with fibroadenomas, if they're small and not causing any symptoms, again, observation with regular monitoring is a great approach.
Okay.
But if a fibroadenoma is large or it's growing rapidly or if it's causing pain or discomfort, then surgical excision might be the best option.
And I know there have been some, advancements in surgical techniques. Are there any less invasive options available these days?
There are. So cryoablation and vacuum-assisted excision are two less invasive techniques that are becoming increasingly popular. So cryoablation uses extreme cold to freeze and destroy the fibroadenoma. And then vacuum-assisted excision basically removes the lesion through a small incision using a needle.
Okay.
So they're good options for the right patients.
Yeah, those sound like great alternatives for patients who are eligible.
Yeah.
It's really fantastic to see these advancements, that can minimize scarring and recovery time.
Yeah, it really is. But it's important to remember that not every patient's a candidate for these less invasive procedures. The bulk treatment approach is always going to depend on the specific characteristics of the lesion and the individual patient's circumstances.
Right, that makes sense. Now, what about sclerosing adenosis?
Yeah.
How do we approach treatment for that one?
So sclerosing adenosis is one of those where treatment isn't always black and white. If it's not causing any symptoms and it's not associated with atypia, observation is often going to be the most appropriate thing to do.
Okay.
But if it's causing pain, then we might consider pain relievers or even in some cases surgical excision.
And I imagine things get a lot more, complicated when we're dealing with those high-risk lesions that are associated with an increased risk of breast cancer, like atypical ductal hyperplasia or lobular carcinoma in situ.
Yeah, for sure. Those situations definitely require more careful consideration and those really in-depth conversations with the patient.
Yeah.
We need to really talk about their individual risk factors, the potential benefits and risks of the different treatment options, and help them make the best choice for their own individual situation.
So what are some of the options for, I guess, reducing breast cancer risk in these higher risk patients?
So one option is close monitoring with more frequent breast exams and imaging just to really catch any changes early. Another option is what we call chemoprevention, which is using medications like tamoxifen or raloxifene to try to lower the risk of developing breast cancer.
Okay.
And then in some cases, prophylactic surgery might be considered.
Yeah.
So that might be something like a mastectomy or a bilateral prophylactic mastectomy to actually remove the breast tissue and reduce the risk as much as possible.
Wow. Those are some really big decisions. I imagine those conversations with patients can be very emotionally charged,
Yep.
both for the patient and the physician.
They can be, these are complex and sensitive topics, and it's so important to approach these discussions with empathy and understanding. The goal is to really empower the patient to make an informed decision that aligns with their own personal values and preferences.
Yeah, and this is where I think that shared decision-making becomes even more important, right?
Yeah.
Really ensuring that the patient feels, involved and supported throughout the process.
100%. It's about working together as a team, respecting the patient's autonomy, and ultimately coming up with a plan that feels right for them.
So we've covered, a lot of ground today. We've explored, this diverse world of benign breast diseases, delved into the intricacies of diagnosis and management, and emphasize, I think, the importance of clear communication, shared decision-making, and just providing compassionate care to our patients. Is there anything else that you want to highlight before we wrap up this deep dive?
I think it's important to remember that benign breast disease, while it is common, can be incredibly stressful for patients.
Absolutely.
They may be worried about their future health, their body image, even their mortality in some cases.
Yeah.
So we as clinicians need to be very sensitive to those anxieties, approach our patients with empathy and understanding, just validating their concerns, providing reassurance, offering resources and support can really make a world of difference for these patients.
Yeah, it's funny. We started this deep dive talking about how common benign breast diseases are,
Yeah.
how we see them every day in our practice. But what really struck me, I think, throughout this conversation is, the complexity,
Yes.
the nuance that's involved in managing these conditions.
Yeah.
It's definitely not as straightforward as it might seem at first glance.
I completely agree. It's a field that requires, ongoing learning, careful clinical judgment, and just a really commitment to providing that patient-centered care. And I think that's a great message, really, for all of us to take away from this discussion.
I think that sums it up perfectly. So as we wrap up this episode of the Deep Dive, I want to leave our listeners with a final thought to ponder. Given the wide range of benign breast conditions and how they can sometimes mimic more serious concerns, how can we, as general practitioners, strike that perfect balance between, thorough evaluation, but also avoiding those unnecessary interventions?
Right.
It's a question that I think requires careful consideration as we navigate these, the complexities of benign breast disease in our everyday practice.
Yeah, it's a question worth reflecting on. And I think the answer lies in staying informed about the latest research, the guidelines, really honing our clinical skills. But most importantly, I think building those strong relationships with our patients that are based on trust, open communication and that shared decision-making that we talked about.
Absolutely. I think that's a great point. Well, thank you so much for sharing your expertise with us today.
Ah.
This has been, an incredibly insightful and informative deep dive.
Oh, it's been my pleasure. And I hope our listeners feel, a little bit more equipped to navigate this world of benign breast disease and provide the best possible care to their
I'm
patients.
confident that they do. And to all of our listeners out there, thank you for joining us on this journey of discovery. We'll be back soon with another deep dive into a fascinating medical topic. Until then, stay curious, stay informed, and keep up the great work.